leading into that, though, let me introduce Dr. Gabriela Hobbs, Gabby Hobbs, who's Assistant Professor of Medicine at Harvard Medical School and Clinical Director of Leukaemia at Massachusetts General Hospital. She works alongside scientists that did the preclinical work on PXS-5505 in myelofibrosis models, and is going to take you through an overview of both the clinical trial that's being undertaken and some of the reasons why that's such a prospective treatment option. Thanks, Gabby.
Thank you so much. Let me get my slides up and ready for you guys. So I'm really excited to have an opportunity to talk to you a little bit about this study. I've been, like you mentioned, Michael, involved in the development from the work in the mice up until the clinical trial. So it's exciting to see it where it's at right now. So since myelofibrosis is a pretty rare disease that few people know that much about, I'll take you through what myelofibrosis is, what the current treatment landscape is for this disease. I'll discuss a little bit about drugs that are currently in development, and then finally end up with the rationale for why LOX inhibition makes sense for myelofibrosis. So myelofibrosis is a disease that affects the bone marrow. And this here is a picture of a bone marrow, and you see those black little lines. Basically, that's scarring that occurs in the bone marrow. And when scarring occurs in the bone marrow, it basically gets in the way of the production of blood cells. And when blood can't be made in the bone marrow, of course, that's problematic, but the body adapts to that by trying to make blood in the spleen. So this massive organ here, this is a CAT scan of a patient, is the spleen. And basically the spleen tries to take over to make blood, and it can become very, very enlarged. And so patients with myelofibrosis can live with tremendous symptoms just from living with a big spleen, and also from having deficits in their production of blood from having a bone marrow that doesn't work normally. So not all myelofibrosis is the same, and we use different scores to predict how patients are going to do. And patients that have kind of low risk myelofibrosis tend to do pretty well. As you can see from the flat line up top, they have a very good life expectancy. However, patients that fall under the intermediate risk groups or the high risk groups really do have a significantly shortened survival. And for those patients, really the only curative therapy, or the only therapy that's capable of modifying the underlying biology of this disease, changing the fibrosis and curing the disease, is a bone marrow transplant. But unfortunately, many patients can't get this treatment because it's pretty risky. So in the United States, there's about 18,000 people living with myelofibrosis. The average age of diagnosis is around 65. And a significant percentage of patients with myelofibrosis will transform to acute leukemia, which is a condition that is associated with a very poor prognosis once it happens. In addition to that, patients really do live with very significant symptoms, including profound and debilitating, sometimes itching, fatigue, as well as splenomegaly, or symptoms from a large spleen. The fascinating thing about studying myelofibrosis is that over the last couple of decades, we've really developed a really deep understanding about the genetics and the biology of this disease. And so this is a schematic. If you can imagine, this is a cell. And this green line is a cell, and there's receptors on the surface of cells, and cells communicate with each other in their environment through receptors. In myelofibrosis, there are mutations, genetic mutations that activate enzymes inside of the cell and make these pathways be continuously active, which leads to increased production of cells and makes these cells not die the way they're supposed to. And in addition, this pathway called the JAK-STAT pathway, which is abnormal in myelofibrosis, is associated with significant inflammation. And so patients have a lot of these symptoms due to the overactivation of this pathway. And so we really understand in depth the mutations that these patients have. The most common mutation is a mutation in a gene called JAK2, followed by another mutation called calreticulin, and then another mutation called MIPL. And so basically, we have a good sense of what's going on from a stem cell perspective and a genetics perspective. And that has helped to develop some more targeted therapies, but we're not quite where we need to be. So here's kind of a general overview about how we approach the disease to patients. So like I mentioned before, there are different scores that we can use to decide if a patient is in a low risk category or in a higher risk category. And that helps us to make decisions in particular about who needs to get a transplant. So there's some patients with myelofibrosis that really have a pretty indolent course. They don't have a lot of symptoms and they can be observed. Then there's some patients that have significant symptoms from either having an enlarged spleen or simply from the inflammation that I was talking about before. And those patients can have really debilitating itching, night sweats, weight loss, and very significant fatigue. And so to treat those symptoms, there are now, at least in the United States, there are 3 what are called JAK inhibitors, or medications that block that pathway I was talking about before. The first one to be approved was a drug called ruxolitinib, or Jakafi is the brand name. And then there's 2 drugs that were approved afterwards, fedratinib, and then most recently, about a week ago, is pacritinib. And I'll talk about those a little bit more later. Then there's, patients that really suffer primarily from low blood counts. And for them, there's really not a whole lot to do. We have some medications like growth factors, but they really don't work very well. And then lastly, there's patients that are in the higher risk categories. And so those patients really need to be referred for a bone marrow transplant or a clinical trial. And like I mentioned initially, not every patient is a candidate for a bone marrow transplant, in part because a lot of the patients are older when they're diagnosed, and many of them have other medical conditions that preclude them from this treatment. So again, low risk patients can be observed. If you have symptoms, you get a JAK inhibitor. If you have low blood counts, basically limited options. So really new treatments are needed. And unfortunately, the only curative therapy is a transplant. And if a patient is transplant ineligible, there are very poor outcomes. So let's talk a little bit about the JAK inhibitors, which are really, the standard of care for patients with myelofibrosis. So the benefit of these drugs is that they're easy to take. They're all pills. Unlike many cancers, you don't need IV chemotherapy or anything like that. They do lead to very significant symptom improvement, spleen size reduction, although they won't do it completely for every single patient. They may have a survival advantage, especially for those patients that have those very significant spleens. Patients are able to then start eating, gain weight, and regain some of their functional quality of life. The downside is that it also affects blood counts. So patients already can struggle from low blood counts because they have myelofibrosis, and then you give them a medicine that makes that worse. And importantly, these drugs are really just palliative, meaning they treat the symptoms, but they don't alter the disease biology. They don't do anything for that cell that I showed you that has those genetic mutations. It doesn't make those mutations go away. It doesn't alter the ability of the disease to progress. So if that patient is going to have myelofibrosis that wants to progress to acute leukemia, that'll happen whether or not they're on a JAK inhibitor. Eventually, patients will lose a response. And once patients lose a response, their outcomes are pretty poor. So Jakafi and the other JAK inhibitors are basically excellent anti-inflammatory drugs. So this is a slide to basically show you that there are a lot of drugs that are being studied for myelofibrosis. So in part because we have such better understanding of the biology of this disease, because there really has been an explosion in the investigation in myeloproliferative neoplasms and myelofibrosis in particular, there's a lot of new drugs. But the thing that I wanted to highlight, Rux being ruxolitinib or Jakafi, is that the first 4 studies that I have on this slide are basically add-ons. So ruxolitinib, patients that don't have a good response, and then you add another drug on top of that. So they're all very similar in kind of their approach to how they're treating myelofibrosis. And then the bottom ones are basically, all of them are JAK inhibitors. So it's pacritinib, which just got approved, jactinib, another JAK inhibitor, and basically it's just a variety of JAK inhibitors. The only one that's novel would be imetelstat, which is a telomerase inhibitor. And so with that in mind, I wanted to discuss the role of lysyl oxidase inhibition in myelofibrosis. So lysyl oxidases are important in making scar tissue in general. There are 5 LOX enzymes in mammals. And in myelofibrosis, investigation has demonstrated that there's elevated expression of most of the LOX enzymes. So PXS 5505 is a pan-LOX inhibitor that is really importantly well tolerated without any off-target activities. And this shouldn't be underestimated, because most of the drugs that are utilized for myelofibrosis, including the JAK inhibitors and the drugs that are being studied, really do have a lot of toxicities and off-target activity that really leads to the side effects of those drugs. So why does LOX inhibition make sense? Well, the first, myelofibrosis is a scarring disease. So if you have a medication that can block the development or the deposition, meaning like the occurrence of fibrosis in the marrow, of course, that intuitively makes sense, but it's more complicated than that. So we know that megakaryocytes, which are these big cells here, which are the precursors of the cells that make platelets, these cells are abnormal in myelofibrosis. There's too many of them. They don't mature well. And the immature precursors of the platelets, the megakaryocytes, produce too much lysyl oxidase. And they lead to a lot of deposition or a lot of production of scarring. And this, the development of scarring ends up leading to increased levels of inflammation, which then again leads to more problems with having low blood counts and more inflammation, and this vicious cycle. And in addition, when we have a lot of the stress, et cetera, there's activation of this other receptor. So I've talked about receptors a lot today. And one receptor that gets activated is this receptor called PDGFR beta. And when that gets activated, it also tells the cells to grow, to produce more megakaryocytes, and in turn to lead to elevated levels of LOX, which then kind of contributes to the continuation of this cycle of inflammation, making more scar tissue, making more megakaryocytes grow, that in turn make more LOX, et cetera. And so blocking this kind of vicious cycle of growth really makes a lot of sense. So the central hypothesis of lysyl inhibition is that by blocking LOX enzymes, we will prevent the forming of scar tissue, basically prevent collagen cross-linking, reduce the fibrosis or the scarring in the bone marrow. And when you can remove and eliminate the scarring in the bone marrow, then you allow for normal blood production to occur. And then once normal blood production can occur, then the blood counts can normalize, and then the spleen can take a break and not try to do what it wasn't supposed to be doing in the first place, which is making blood. And so there have been several studies utilizing this compound. On the left hand here in the green, basically what I'm showing is some of the work that was done by some of my colleagues at Boston Medical Center with mouse models of myelofibrosis. And so you can see mice that have the JAK2 mutation, which is basically the mice that are like the myelofibrosis mice, have very elevated levels of fibrosis. And in mice that are treated with the lysyl oxidase inhibitor, with PX5505, the levels of fibrosis really go down. And so that was demonstrated in mice. Then this compound has been studied in healthy volunteers with really no issues in terms of safety or tolerability, which is really important. And then here I'm showing just some preliminary results of the ongoing clinical trial that demonstrates, inhibition of lysyl oxidase at 7 days and again at 28 days. And so far, what they have seen in the study is that there's really no safety signals that are concerning, and really no adverse events, even at the highest dose. And that's a big deal for a study in patients with myelofibrosis, especially because these are patients that maybe were already on JAK inhibitors or can't tolerate JAK inhibitors, and so presumably have more advanced disease. And so here's just a schematic of the ongoing clinical trial. The phase 1C component of the study is complete, and their endpoints are pretty standard in terms of what is done in myelofibrosis studies, looking, initially to make sure that their targets are being hit by looking at PK or pharmacokinetics and pharmacodynamics. They're investigating bone marrow fibrosis with treatment, as well as seeing response, that's the IWG, looking at spleen volume response, making sure that there's changes in the symptoms as well as the blood counts. And with that, I'll conclude. And this is a picture of the view from my hospital on Sunset. Thank you all.
Thank you very much, Gabby. We're now going to start with some Q&A, and I'd like to introduce some Q&A panelists to kick things off and hopefully ask the meaningful questions that all of I guess the participants here want to ask from an investment perspective. So first we have Hashan De Silva from Cast Peak. We have Bianca Ogden from Platinum. We have Dennis Helm from Taylor Collison and Derek Delinek from Morgans. So I'd like to welcome those Q&A panelists, and perhaps we can kick off and see if does anyone want to volunteer the first question, or shall I pick somebody?
I can ask the first question. Thanks very much. That was a great overview. If we go back to how the disease starts and kind of like have a quick look at, does it start with the inflammation? So is it the mutation that then drives inflammation, then scarring, or what is it really that kicks it off?
It's all about the genetics. And so it starts out by a mutation that occurs for unknown reasons, and what's called a hematopoietic stem cell, or a blood producing stem cell. And that mutation, or I showed you several different mutations, lead to the production of a lot of inflammation. And so the effects are not just in the cells that produce blood, but really it's what's called the stroma, or the surrounding infrastructure of the bone marrow, if you will. And I think really that biology is not entirely understood. What exactly is it that leads to the deposition of fibrosis? And it definitely has to do with inflammation, and a little bit of that pathway that I showed in terms of how lysyl oxidase itself is involved in that, the activation of these other receptors like PDGFR beta, et cetera.
Right. And if you, for example, the JAK inhibitor is obviously the one that kind of started the treatment paradigm with the target therapies. But is there any other things in development? For example, you mentioned several other receptors. Has there been work going on to really, I guess, tackle it from different sides?
It's a great question. And I think it's really interesting because I've been involved in participated in a variety of other clinical trials and spoken to other companies that have, some of those drugs that I showed you in development now. And I mean, this is a little bit of an unfair statement, but for the most part, most of those studies that are now going into phase 3 weren't rationally designed. And so really the only drugs that were sort of specifically designed for myelofibrosis are the JAK inhibitors. And that was kind of low hanging fruit. You're like, okay. Yeah. And that was, taken from other diseases in oncology that have a mutation, especially in leukemias. Like there's a mutation, it's an activated enzyme. We have the technology to block that enzyme. Perfect. And so it made a lot of sense to use JAK inhibitors because no matter your mutation, that JAK-STAT signaling pathway is going to be active. So that was really the easy hurdle to overcome. And then we realized, myelofibrosis is not that simple. So blocking one enzyme is not going to make the disease go away, or it may just be that we don't have the correct molecule yet to block that pathway very specifically, which we can talk about more if you're interested. But the other drugs that are being developed, like the BET inhibitor, like the navitoclax, which is an apoptosis drug, the BCL2, BCLXL inhibitor, that are going into phase 3, or there's this other one that was also in that slide, a PI3 kinase inhibitor. When you talk to any of the folks in the companies that are using these drugs, they were using those drugs for basically any disease that they could, and then they were like, "Oh, I guess we should test it in myelofibrosis." And honestly, they were surprised that some of those drugs had efficacy, but it wasn't specifically designed with the biology of myelofibrosis in mind. If that sort of answers your question. So yes, they're tackling some activated receptors like PI3 kinase. And, so then there's like, oh yeah, no, we do have activation of PI3 kinase in myelofibrosis. So sure, it makes sense to inhibit it, but it wasn't like it was specifically designed for myelofibrosis because that pathway is active. You know what I mean?
Yeah. So it is in the end a combination. Look, I step back. I've got lots of other questions, but I'll let my other panelists ask questions.
Thanks, Dr. Hobbs. Shan here. Just a quick question on the clinical progression of the disease. So when are patients diagnosed specifically with myelofibrosis? Is it a genetic test like you mentioned, or is there some kind of clinical progression from myelodysplastic to myelofibrosis? And then I guess the second part of the question is, where do you think this drug would fit in? And does it make a difference at treating the patient at a different stage?
Yeah, great question. So in terms of how patients are diagnosed, it really varies. Some patients go for an annual checkup, doctor gets a blood count and something's abnormal, and that leads to some more testing. Some patients really have a lot of symptoms. Like I said, they all of a sudden have a lot of like abdominal pain, and they're found to have a large spleen, and that leads to additional testing. But ultimately, the diagnosis is made by doing a bone marrow biopsy, showing that the bone marrow biopsy has fibrosis or scarring, and then molecular testing is obviously critical for the diagnosis of myelofibrosis. And I would say most places in developed countries have the ability to do next generation sequencing and doing at least testing for JAK2, calreticulin, and MIPL, which are the three that are most commonly mutated. And then larger academic centers and honestly, more and more patients are doing these physicians are doing these extended panels where they test for 100 genes at a time. And then you asked me another question.
Yeah, and where in the disease do you think there's
we're in the disease.
Yeah.
Right. So I think there's a lot of potential, honestly, in terms of where this can be used. It makes a lot of sense to use it where it's being used right now, just because of how clinical trials function. You can't kind of give it up front to patients that otherwise would be eligible for standard of care therapies. But based on the fact that it's so well tolerated that it doesn't cause low blood counts, I think that that's huge. That makes it much easier to use this drug maybe a little bit earlier in the disease also, after this study is completed. There's a condition called prefibrotic myelofibrosis, and I think it's important to acknowledge that there's two separate diseases, one called polycythemia vera, one called essential thrombocythemia, and then also the third, prefibrotic myelofibrosis. All of those can progress to overt myelofibrosis. And I think there's lots of opportunity to be able to use a drug that prevents that fibrosis from forming in the bone marrow to prevent, the progression to myelofibrosis. So it's not just a drug that I think could be used for advanced myelofibrosis. I think it could be used earlier on. And the fact that it's really like a very well tolerated medication makes it very appealing, because a lot of the other medications that we use do have a lot of other side effects. Even the JAK inhibitors that are really relatively very well tolerated are pretty immunosuppressive. So patients can end up getting infections and things like that. And so if you have a drug like this one, I think I can envision, and I know I've talked to Wolfgang about other places where I think it can be used. You can use it probably in myeloproliferative neoplasms in general. So
great. I'll get back in the queue.
Okay, well, I'll jump in and take my opportunity. Gabby, you mentioned you've been involved in some of the animal studies of the LOX inhibitor. Can you talk a little about how the data you've seen with the LOX inhibitors compared to other drugs you've looked at in myelofibrosis or drug candidates?
You mean in mice specifically?
Yeah, well, in animal models and in mice, yeah.
So I work basically with the investigator that work with the mice. I'm definitely not a lab investigator. But when you look at the results, at least, or the published literature, you can see the results from Dr. Ravid. She very clearly demonstrates that lysoloxidase enzymes lysoloxidase is elevated in myelofibrosis, or her model of myelofibrosis, and that the fibrosis goes down when you block it with lysoloxidase inhibition. And that leads to, shrinkage of the spleens and improvement in the blood count. So it's a nice model in the mice. Of course, we need to translate that over to people.
Yeah. Okay. And just moving on. Just moving on to clinical trials. Initial trial is testing the drug in JAK intolerant patients. So do you see any issues in combining the LOX inhibitor with the JAK inhibitor? Do you think that's going to be a suitable combination going forward?
I think that's a logical combination. And I think, kind of similar to the question I answered before, one of the nice things about this drug, and really shouldn't be underestimated, is that it's a very well tolerated medication, and very specifically and really importantly is that it doesn't cause worsening blood counts. What I think is fascinating as an MPN investigator, as a myelofibrosis investigator, is that most of the drugs that are being developed exclude patients that have low blood counts. Can you believe that? And that I've never understood that, because that's what the disease is, right? So, you know, Jakafi got lucky because they were the first. And so they could include patients that just had splenomegaly and symptoms. But there's a group of patients with myelofibrosis that maybe have splenomegaly and symptoms, but also have low blood counts. And all of those patients are excluded from all of the clinical trials that I showed, except for this one. This one doesn't exclude patients that have low blood counts. And I think that positions it in a really good, in a really good way to then say, you know, we can add it to patients that are on Jakafi that maybe don't have a complete response or that have low blood counts. There's like a few studies that have allowed patients with low blood counts. Pacritinib is the JAK inhibitor that was just approved for patients with platelet counts of less than 50, but it was approved only because it's safe in patients with platelets of less than 50, not because it improves the platelets. So I think that, you know, this drug is unique in that way.
Well, thanks very much. That's very encouraging. I'll step back into the queue.
Derek, did you have any questions?
Yeah, I guess I'm pulling up the rear here. Don't slap me in the face, would you? No, just that was a great talk. Great talk. I really appreciate it. But I guess, given our understanding of the heterogeneity of this disease, I mean, you put a slide up. It's interesting that the outcomes, overall survival outcomes, are varying from 2 to 7 years. That just shows you, for me anyway, that we really need a better risk stratification strategy. Anyway, getting back to where you said where you think 505 would be placed, I think it's very interesting. Is it the pre-fibrotic patients? Is it the post-fibrotic primary MF? Is it post-ET? Is it post-PV?
Right.
I'm looking at the inclusion criteria specifically in the trial. I wanted to get your 2 cents on, do you think it's valid to start in patients that are high risk, medium risk, and that have grade 2 fibrosis already?
I think that that's how you have to start. I don't think you have a choice, unfortunately. And then we could probably have a longer conversation about should clinical trials be designed this way. But when you have other drugs that are approved earlier on in the disease and you're just getting started with phase 1 studies, that's pretty traditional. You know, you go to the back of the line and you start with patients that have already failed those drugs or aren't eligible for those drugs. So I think it makes a lot of sense to start out there. But I do think that there's potential, especially because it's well tolerated, it doesn't lower blood counts, hopefully it'll improve blood counts. That then makes an argument for saying, why don't we try it earlier on? Why don't we try it in patients that have, you know, myelofibrosis that need a JAK inhibitor, that have low blood counts, that perhaps can't get the therapeutic dose of the JAK inhibitor because they're going to have low blood counts. What if we add, you know, this drug, improve their blood counts, and then we can give them a full dose of the JAK inhibitor and improve their symptoms, et cetera. And then in terms of risk stratification, we have like 15 different scores to risk stratify patients based on their molecular genetics and this mutation and that mutation. And I can sit with a patient and be like, based on the fact that you have a JAK2 mutation, an AXXL1 mutation, an IDH mutation, this mutation, you're going to have an overall survival of 2 years. Yeah, you need to have a bone marrow transplant, but guess what? You're not a candidate. So I'm not really sure that we need better risk stratification systems. You know, like I showed like a very crude slide of an older risk score that we use. We definitely know how to stratify patients and tell patients like you fall under the 1 year or 2 years or 4 years or whatever. We need therapies that make a difference there. And really the only therapies that make a difference in terms of how long people live and who's cured is stem cell transplant. And although definitely stem cell transplant has become much better tolerated for myelofibrosis patients, very few patients actually end up getting transplants. I even think that like we could use this drug after transplant when it takes about 3 to 6 months for the fibrosis to go away after transplant. How wonderful would it be to speed that process up, you know? So anyway.
All right, we've got a couple more minutes. Does anyone else want to volunteer a question, or I can certainly ask one if no one else does?
I've got lots of more questions. When you look at the trial designs and for example, what is your ideal outcome that you would like this particular drug to do? What do you focus on the most? And it's, I guess, the most clinically relevant one.
That's a loaded question. So, you know, the studies in myelofibrosis have been stuck in two things: improving symptoms and improving the spleen. And that's kind of like the benchmark. But I don't think that should be the benchmark, because, you know, though improving those things doesn't improve progression-free survival, and it doesn't improve overall survival. It also doesn't improve or talk at all about blood counts, and it doesn't talk to you at all about progression to leukemia. And so, I mean, I think initially for a phase 1 study, you have to just make sure that the drug is safe. You know, that's all you can hope. And so for this drug, I think the fact that so far we've seen that it's safe, that it doesn't have, you know, any significant adverse events, that there's not, you know, significant blood, you know, cytopenias, I think that's huge.
Yeah.
Of course, later on, I want to see in all these studies in myelofibrosis, I want to see something that's not just, we want to make sure that the spleen volume reduction is greater than 35% at 24 weeks. That's all of the trials have those same endpoints that are just not that.
Not really exciting.
It's not that exciting,
but,
because, you know, when you look at oncology, drugs don't get approved because you make a person feel better. Don't get me wrong, that's huge. Of course, I want to make my patients feel better, but I want them to live longer. So I want progression-free survival to be an endpoint. I want leukemia-free survival to be an endpoint, overall survival to be an endpoint. I want to see the levels of those mutations go away and the blood counts to improve and normal hematopoiesis to be restored. But none of the drugs that I pointed out before do any of that.
But do you think that obviously it's going to go combinations, it won't be one drug will solve that, but do you think a combination of a LOX inhibitor plus the JAKs can push that progression-free survival in the right direction? Is that a powerful combination, do you think?
I mean, the JAK inhibitors we know are not going to do that, right?
No.
But the JAK inhibitors do a lot of nice things. So they make a person feel better, they shrink their spleen, they lower the inflammation. And so, yeah, perhaps lowering of the inflammation in several different ways makes sense. And so if you can turn off those cells and then also block the deposition of more fibrosis, yeah, I agree. I think that one drug is not going to do it. I mean, it'd be great if one drug alone did do that. But I do think that it makes sense, for sure, it makes sense to combine with a JAK inhibitor. That's, I think, the next step.
Yeah, cool. Thank you.
Thank you so much, Gabriela. I'm sure we have a lot more questions between us, but unfortunately, we might have to take some of those up towards the end of the session in the closing Q&A.